Thanks, Jamil. So everybody get out your audience clicker. This is supposed to be interactive and answering questions before we go to lunch. So case 1 is a 53-year-old Caucasian man with diabetic nephropathy who underwent a deceased donor renal transplant 6 months ago, who comes in for routine follow-up. He received ATG for immunosuppression induction, followed by maintenance therapy, including tacrolimus, mycophenolate, and prednisone. His post-transplant course was complicated with acute cellular rejection, grade BANF 1B, about 8 weeks after transplant that was treated with ATG and high-dose steroids. His function eventually stabilized to a creatinine of about 1.5, and today he feels overall well and his physical exam is unremarkable. Labs show that his creatinine is now elevated to 2.0. His CBC is within normal limits, and his tacrolimus trough level is 8 nanograms per milliliter. His serum PCR for BK polyomavirus is positive for the first time and is detected at 80,000 copies per ml. So which one of the following statements is most correct regarding management of his case? A, start another course of ATG and high-dose steroids for suspected acute cellular rejection. B, perform an allograft biopsy followed by a decrease in maintenance immunosuppression if there's no evidence of acute rejection. C, start IV cidofovir. D, switch from tacrolimus to sirolimus. Or E, add leflunomide. All right, go ahead and answer. All right, let's see. So there's an overwhelming response for B, which is correct. So you want to perform an allograft biopsy because of the concern for potential BK nephropathy. So with the evidence of the positive BK viral load, you need to be suspicious about that possibility. The definitive diagnosis of BK nephropathy, of course, requires an allograft biopsy. And what one should be aware of here is that the histological features of acute cellular rejection and BK-induced inflammation can sometimes look very, very similar. And so sometimes what you need to do is have the BK staining for the SV40 virus in order to make the distinction between BK and ACR. There are, in some centers, if you see a lot of inflammation, even if there is evidence of BK nephropathy on the biopsy, we will often pulse them with some steroids and then reduce the long-term maintenance immunosuppression. And the reason for the slight pulse in the steroids to begin with is to lyse the infiltrating lymphocytes to decrease the amount of inflammation in the allograft. But there's no good treatment options other than lowering of maintenance immunosuppressants for these patients. So case 2 is a 45-year-old Asian man with end-stage renal disease from polycystic kidney disease who underwent a second deceased donor renal transplant about 6 weeks ago. His first transplant had failed due to chronic rejection. He's here in routine follow-up. His graft function has been excellent with a creatinine of around 1.2. And his last lab testing showed that creatinine level with a tacrolimus level of 10. His CBC was within normal limits. 5 days ago, he underwent an EGD for ongoing odynophagia and was diagnosed with Candida esophagitis. And for that, he was started on fluconazole 200 milligrams PO daily. Today, he reports that his odynophagia has resolved and he feels overall well. He takes tacrolimus and mycophenolate for his maintenance immunosuppression, and his labs today indicate a normal CBC, but his serum creatinine is elevated at 1.6 milligrams per deciliter. Which one of the following statements is most correct regarding further evaluation and management of his case? A, start pulse steroids since he is at high immunological risk for acute rejection. B, wait for the tacrolimus level to come back since fluconazole can significantly increase tacrolimus metabolism. C, wait for tacrolimus level to come back since fluconazole can significantly decrease tacrolimus metabolism. D, switch tacrolimus to cyclosporin since the latter has no interaction with fluconazole. Or E, arrange for an urgent biopsy to rule out rejection and or CNI-induced TMA. So go ahead. All right, we seem to be leveling out at around 50, but I think there are much more than 50 of you here. All right, so everybody fell into the grammar trap of these questions. And so everybody realized, or most people realize, that there's a distinction and a concern for interaction between your azoles and your calcineurin inhibitors. And in this case, the correct answer was that the fluconazole can significantly decrease tacrolimus metabolism, leading to increased levels of serum tacrolimus levels. Okay, so the reason for this interaction is because both are metabolized by the CP450 system, in particular the CYP3A. One needs to be cognizant of all the antifungal agents like fluconazole, ketoconazole, voriconazole, itraconazole. Other medications that commonly result in decreased tacro metabolism with increased levels include diltiazem as well. So often people might put them on DILT for heart rate or blood pressure control, not realizing that this could have adverse effects on levels. And similarly, when they're taken off of these medications, one needs to be cognizant of then appropriately compensating for the fact that the levels will now decrease, and so you need to increase their dosages. Case 3. A 52-year-old Hispanic woman with end-stage renal disease from diabetic nephropathy. She underwent a living-related renal transplant from her sister about 18 weeks ago. Their CMV serostatus were as follows. The donor was IgG positive, recipient IgG positive. EBV serostatus was donor negative and recipient negative. She received ATG for induction therapy, followed by maintenance with tacrolimus, mycophenolate, and prednisone. She's here for a routine follow-up and reports ongoing diarrhea, nausea, and bloating. Blood pressure is 118/70, heart rate of 90. She's afebrile, and her physical exam is unremarkable. Her hemoglobin is 8, white cell count of 1.4, platelets of 90,000. Her renal allograft function is stable with creatinine of 1.2 and a tacrolimus level of 8. She currently takes Tacro 3 milligrams BID, MMF 1 gram BID, and prednisone 5 a day for immunosuppression. Her prophylaxis includes valganciclovir and TMP SMX. Which of the following statements is most correct regarding further evaluation and management of her case? A, decrease the MMF dose and send a serum CMV PCR. B, decrease the tacrolimus dose and send a serum CMV PCR. C, continue MMF at the current dose since diarrhea and nausea are rare side effects of MMF. D, stop valganciclovir since she has leukopenia and is at low risk for CMV infection. Or E, increase the valganciclovir to 900 milligrams BID to start empiric treatment for CMV disease. Go ahead. All right. So most of you correctly stated that the answer should be A, which is decrease the MMF dose and send the serum CMV PCR. So, of course, to review what Dr. Gabardi spoke about this morning, the most common adverse effects of MMF are GI-related, diarrhea occurring in about a third of the patients and varying degrees of sort of bloating, nausea, dyspepsia in about 20% of the patients. He spoke about splitting up the doses or using enteric-coated MPA, but both have anecdotally helped some patients, but for the most part do not. It's really dose reduction, if possible, that is most helpful. Of course, MMF can cause pancytopenia, and again, this usually responds to a reduction in dose. Leukopenia is rare for tacrolimus. And of course, valganciclovir can also cause bone marrow suppression, but stopping it would be premature since she's at moderate risk, being CMV D plus R plus, for both reactivation of CMV and or superinfection with a new viral strain from the donor. In some cases, if you decide that the MMF dose reduction is not possible because she's high immunological risk, then potentially you can take off the valganciclovir and do preemptive monitoring of CMV viral loads and treat. So you're checking CMV viral loads in your lab work every 2 weeks or so. And if there's any detection of viremia, then putting them on treatment doses of valganciclovir. So again, it's always a sort of a balance between what's the lesser of two evils. Case 4 is a 45-year-old woman who comes to your clinic complaining of fatigue, weight loss, and abdominal pain. She had a deceased donor renal transplant more than a decade ago due to FSGS. Graft function is stable on tacrolimus, MMF, and prednisone. An MRI reveals a circumferential mass, approximately 4 centimeter segment of the jejunal loop in the left upper quadrant, without any evidence of obstruction. Which of the following statements is regarding PTLD after kidney transplant is correct? A, EBV seronegative status of the recipient at the time of transplant and induction with a T-cell depleting antibody have been associated with increased risk for the development of PTLD. B, PTLD occurs only in the first year after transplantation when the patients are most highly immunosuppressed. C, while the majority of cases are not caused by EBV, EBV-associated PTLD does occur. D, rituximab is not an effective treatment since most PTLD is of T-cell origin. Or E, treatment includes increases in basal immunosuppression. Go ahead. All right, so the majority of you correctly answered A, but there were a few of you who thought that C was potentially correct. So C was, while the majority of cases are not caused by EBV, that's the incorrect part, as the majority of cases are EBV associated. Okay, so as I said, the correct answer is A. If you've used any sort of lymphodepleting agent, that puts you at your recipient at higher risk. If the recipient is EBV naive or IgG negative, then they are also at increased risk. While the incidence appears to be highest during the period of highest immunosuppression, the cumulative incidence post the first year is also on the order of 1 to 3%. So you can develop late PTLD. Most are non-Hodgkin's lymphoma and are of B-cell origins and are therefore CD20 positive. And so rituximab alone or R-CHOP in some cases are sort of the mainstays of therapy. Case 5, 65-year-old Asian man with ESRD from PKD. He had a living-related transplant from his nephew about 8 months ago. CMV D plus R negative, EBV D plus R negative. He had an episode of ACR, cellular rejection, grade BAMF1B, about 5 months post-transplant, for which he was treated with ATG and high-dose steroids. Today he reports fever, chills, and malaise for about a week's duration. He's tachycardic with a heart rate of 101, blood pressure 115/65, temp of 103 Fahrenheit. Otherwise, his physical exam is unremarkable. Lab tests show a hemoglobin of 7.5, white cell count of 1.2, platelets 95,000. His creatinine is 1.4, and his tacro level is at 7. AST and ALT are 150 and 188, respectively. UA is unremarkable, and a chest X-ray is pending. So his maintenance immunosuppression is currently prednisone, tacro, and MMF, and he's on TMP SMX prophylaxis. Which of the following statements is most correct regarding his case? A, you want to arrange for a renal allograft biopsy to rule out BK. B, send serum polyomavirus PCR and start IV cidofovir while awaiting the result. C, CMV disease is unlikely since the patient is CMV seronegative and therefore at low risk. D, PTLD is unlikely since the patient is EBV seronegative and therefore at low risk. Or E, the initial workup should include serum CMV PCR. Right, go ahead. All right. So, good. So the majority of you suspected potential CMV disease, and so the initial workup should include a CMV viral load. Just to go over the issues. This patient is the highest risk for CMV infection and disease because the donor was seropositive and the recipient was seronegative or IgG negative. Importantly, he also received recent anti-rejection treatment with both high-dose steroids and a lymphodepleting agent, putting him at further risk of developing CMV viremia and CMV disease. In fact, in many institutions, even if you're past that 6-month prophylaxis period where we use valganciclovir for prophylaxis, if you are receiving further treatment with high-dose steroids plus or minus lymphodepleting agents, we will also start you on prophylaxis valganciclovir for usually about 3 months period of time. The use of the CMV PCR is what you want to look for in terms of deciding about diagnosis and how to monitor disease and response to antiviral therapy. This is not BK because BK doesn't usually cause systemic symptoms. And I don't think anybody had any questions about the PTLD issues. All right.
Thank you, Dr. Young. This is the case of a 48-year-old woman who had ESRD from lupus, and this is her second deceased donor transplant 3 weeks ago. CMV was donor positive, recipient positive. EBV was donor positive but recipient negative. And the first transplant failed from chronic antibody-mediated rejection. The course was complicated by delayed graft function and need for dialysis. A biopsy on day 7 showed severe acute tubular necrosis. And now on 21 days post-transplant, the patient still is oliguric and dialysis dependent. So you decide to do a renal biopsy, and it shows ongoing ATN, but also neutrophils in the peritubular capillaries. C4D staining is diffusely positive in those peritubular capillaries, and duplex ultrasonography was unremarkable, showing no obstruction, for example. She takes tacrolimus and MMF for maintenance immunosuppression. Which one of the following statements is most correct regarding her case? 1, arrange for a renal allograft biopsy to rule out BK. 2, check for donor-specific anti-HLA antibody and arrange for possible pheresis in IVIG. C, treatment for T-cell mediated rejection with ATG and pulse steroids. D, send a BK PCR and decrease the MMF dose. And E, switch from tacrolimus to belatacept since calcineurin inhibitors are delaying recovery from ATN. So put in your answers. Okay, And most people said that they would check for a specific anti-HLA antibody and arrange for pheresis and IVIG. The answer is B. You would check for donor-specific anti-HLA antibody, or DSA, and arrange for pheresis and IVIG, because what you're thinking about is the possibility of antibody-mediated rejection, for which the treatment would be plasmapheresis and provision of high-dose IVIG. The antibody-mediated rejection can look like ATN because of the ischemia to the kidney, and there can be thrombotic microangiopathy, there can be fibrinoid necrosis. That's a severe case. And this happens often in the setting of sensitization against HLA antigens. So it's important to stain for C4d positivity, which is a component of complement that is covalently attached to the endothelial walls and stays there in sufficient quantity to be able to easily be detected. So it's useful to repeat if the cross-match is possible. If you want, you can repeat the cross-match in order to see whether or not there's a positive cross-match against the donor, and also to see whether or not there's donor-specific anti-HLA antibody in the recipient. Next. 58-year-old man with reflux nephropathy, ESRD, had a transplant 4 years ago, had antibody-proven ABMR 1 year post-transplant. That was treated with sessions of pheresis and IVIG. He's on maintenance immunosuppression, tacro, MMF, and prednisone. And over the last year, the creatinine had been going up from 1.5 to 3. Biopsy showed glomerular capillary wall thickening with double contour appearance, some intimal fibrosis, intimal mononuclear cell infiltration, and interstitial fibrosis and tubular atrophy. The C4d staining in the peritubular capillaries was positive. Which one of the following is most correct regarding the biopsy findings? 1, or A, anti-HLA antibody specific DSA has been associated with chronic antibody-mediated rejection. B, absence of anti-HLA antibodies rules out the diagnosis of antibody-mediated rejection. C, since introduction of more potent immunosuppressants, chronic ABMR has become a rare cause for chronic allograft failure. D, it usually responds well to treatment with pheresis, IVIG, and pulse steroids. Or E, it usually responds well to Rituxan. Put in your answers, please. I think we're ready. Okay, so most people said A, and very few people had anything else. And the answer is indeed A. The presence of DSA has been associated with lower long-term graft survival, and non-HLA antibodies, for example, anti-endothelial antibodies, which are not HLA, and MHC class 1 chain-related antigens, MICA, have been implicated as potential causes of antibody-mediated rejection. And despite immunosuppressive therapies that are more modern, a good number of chronic allograft loss remains due to chronic antibody-mediated rejection. Up to 60% of patients in some studies show evidence of antibody-mediated injury chronically. And the treatment for this is problematic, not well defined. Pheresis, IVIG, and Rituxan remains of unclear benefit at this time. 52-year-old woman with lupus had a transplant 4 months ago. She received basiliximab, which is anti-IL-2 receptor antibody, as induction, followed by tacrolimus, mycophenolate, and prednisone maintenance. She's been doing well with a creatinine of 1.1, but the creatinine elevated to 1.8 a day ago. Tacro level was 5. Bedside ultrasound showed an allograft of 10 centimeters and no hydronephrosis. The biopsy showed prominent interstitial inflammation and moderate focal tubulitis, mild to moderate intimal arteritis, and it was negative for C4D. What's most correct? A, patient has acute ABMR, antibody-mediated rejection, and you should treat with pharesis, IVIG, and steroids. B, patient has acute T-cell mediated rejection, and treatment with belatacept and pulse steroids should be initiated. C, T-cell mediated rejection and treatment with ATG and pulse steroids should be initiated. Or D, BK nephropathy is ruled out since patient has had an acute rejection. Okay, put in your answers. Okay. And almost everybody said C, that is T-cell mediated rejection and treatment with an antibody against T-cells plus steroids. So the normal definition of acute T-cell mediated rejection relies on the Banff criteria. There was a meeting in Banff and continued to have meetings there. That defines and classifies T-cell mediated rejection depending on presence of tubulitis, interstitial inflammation, and arteritis. So in this case, the rejection is classified as TCR, T-cell mediated rejection type 2. Thymoglobulin and pulse steroids are really the first line treatment, and BK nephropathy and acute cellular rejection can occur concurrently, where, as we said before, where BK nephropathy can have similar histologic features as acute cellular rejection, but it relies on the demonstration of the virus in tubular epithelium. A 69-year-old man with kidney failure from diabetic nephropathy was on dialysis for a year, had a kidney with a cold ischemia time of 28 hours, remained oliguric, and was dialyzed because of hyperkalemia and volume overload. Biopsy was done on day 10 and showed diffuse tubular injury, negative staining for C4D. The patient had received basiliximab for induction and is currently treated with tacro, mycophenolate, and prednisone. And then at 3 weeks, he follows up for follow-up. 24 urine hour output is 300. He's dialysis dependent. Vital signs you see there. He had moderate lower extremity edema. Laboratory tests show normal CBC, creatinine of 8.4, tacro level of 8. Which one of the following statements is most correct regarding delayed allograft function? A, most common cause is acute rejection. B, the risk is nearly the same for kidneys procured from donors after cardiac death. C, the patient's risk factors for DGF include cold ischemia time and calcineurin therapy. D, compared with cold storage, machine perfusion has never been shown to reduce the risk of a DGF. And E, while DGF greatly impacts 1 year survival, it has no impact on the long-term graft function. Choose what you think is the most correct. Okay. So virtually everybody thinks it's number C, which is that the risk factors include cold ischemia time, which is an obvious one, as well as calcineurin inhibitors, which also can cause acute tubular injury. And higher donor age, hypertension, hypotension, cold ischemia time, calcineurin inhibitor therapy, all are factors that can relate to delayed graft function. And Incidence is about 5%, 30%, 50%, and up to 70% in recipients of live donors, standard and extended criteria donors, and donors after cardiac death, respectively. Machine perfusion has been shown to reduce the risk of delayed graft function and is routinely used in higher risk kidneys around the country. Both patient and graft survival rates are adversely impacted by the kidney source and the development of DGF. And this is a 50-year-old woman with polycystic kidney disease on maintenance dialysis. She comes in for evaluation for kidney transplantation. So it's a patient who you might see in your clinics, for example. Medical history includes hypertension and dyslipidemia, has heard that kidney transplantation can cause diabetes and also worsen dyslipidemia, and wants you to tell her something about this. She's concerned about the impact it might have on her long-term health. Which one of the following is most correct? A, annual rate of fatal or non-fatal cardiovascular disease events in kidney transplant recipients is nearly similar to the general population. B, kidney transplantation is known to reduce mortality compared to dialysis, despite significant increases in cardiovascular risk. CMV seronegativity has been associated with increased risk for cardiovascular death. New onset diabetes mellitus after transplantation may occur as a result of insulin resistance, increased insulin metabolism, and or diminished insulin secretion. And E, hyperlipidemia and hyperglycemia are less marked with cyclosporin than with tacrolimus. Give your answers. Okay. And there's a mix here, but most people thought it was B. And in fact, the answer is D. It is true that new onset diabetes after transplantation can occur as a result of insulin resistance, increased insulin metabolism, or decreased insulin secretion. And the mechanisms appear to be mixed, but all of those three things can occur. The tacrolimus can cause direct beta cell toxicity, for example. And transplant recipients have a lower risk of fatal and non-fatal cardiovascular events compared to waitlisted patients on dialysis, but a much higher risk compared with the general population, of course. Reduced mortality after kidney transplantation compared to dialysis may be largely due to reduction in cardiovascular risk associated with improved kidney function. And CMV seropositivity has been associated with increased risk for death as a result of cardiovascular disease.
Right. The next case is a 27-year-old Caucasian woman with end-stage renal disease from primary FSGS, who recently started on maintenance hemodialysis, who's being referred to you for pre-transplant evaluation. She would like to know about the possibility of pregnancy after transplantation. So in counseling her, which one of the following statements is most correct regarding pregnancy after transplantation? A, the pregnancy rate after kidney transplantation is nearly similar compared with the general population. B, she can attempt to become pregnant as soon as her serum creatinine starts to decline, since the risk of graft dysfunction will be low at that point. C, pregnancy has a significant unfavorable effect on long-term graft function, regardless of the baseline graft function. D, mycophenolate is associated with an increased risk of congenital malformations and therefore is absolutely contraindicated during pregnancy. Or E, the use of cyclosporin in pregnancy increases the incidence of hypertension and is therefore absolutely contraindicated during pregnancy. Go ahead and submit your answers. All right, great. So I think this came through in Dr. Gabarty's talk. The correct answer is D. The mycophenolate is associated with an increased risk of congenital malformations and is absolutely contraindicated. So what we try to do is counsel our childbearing female patients that well ahead of time that if they have any intention of becoming pregnant, that they speak to us well ahead of time so that we can make their switch in immunosuppression well before, because not only do we have to make the switch, but we also have to make sure that their allograft function remains stable on a stable dose of whatever we switch them over to. And then following that, then at that point in time is when we counsel them that it's now safe to try and become pregnant. So all in all, it usually takes a couple of months before all that is sorted out. The greatest risk of malformations is usually in the first trimester. And there's also concern that even for those who are donating eggs or saving eggs, for example, that we probably do want to avoid mycophenolate in those situations. Fertility, both male and female, is actually greatly improved within a few months after kidney transplantation. However, the pregnancy rate, as one can imagine, still is significantly lower than the general population. In terms of how long to wait, we usually counsel our patients to wait at least 1 year after transplantation before attempting to become pregnant, and only if their allograft function is stable, with a creatinine less than 1.5 being ideal, and no or minimal proteinuria defined as less than 500 milligrams in a 24-hour period. And in those patients, there's a 90% incidence of successful pregnancies in those patients, according to a number of studies. Usually in those situations, most of the studies have demonstrated that pregnancy is indeed safe and does not have an unfavorable effect on long-term graft outcome. And although cyclosporin has the potential of increasing blood pressure and exacerbating things, it does not seem to be a major teratogen, so it's not an absolute contraindication. It would be something that we would just monitor closely. The next case, which statement is most correct about side effects of maintenance immunosuppressants after kidney transplant? A, both cyclosporin and tacrolimus can cause hypokalemia and hypomagnesemia. B, hirsutism and gum hypertrophy are more common with tacrolimus than with cyclosporin. Oops, nobody saw that. Hopefully most of you were asleep. C, hypertension and uricemia and hyperuricemia are more common with tacrolimus than with cyclosporin. D, sirolimus is associated with de novo proteinuria and exaggeration of pre-existing proteinuria. Or E, since the introduction of enteric-coated formulation of mycophenolic acid, GI side effects are now relatively rare. All right, so most of you got the correct answer, which is D. Sirolimus is indeed associated with both de novo proteinuria due to toxicity to the podocytes themselves, as well as exaggeration of pre-existing proteinuria. And as you heard in Dr. Gabarty's talk, often if patients have a proteinuria of greater than 500 milligrams per day, we will avoid trying to initiate sirolimus if possible. This is true for all the mTOR inhibitors, so everolimus included in that as well. And the other thing too is if we do in fact make the switch over to an mTOR inhibitor, we'll often be adding to their standing labs a urine protein to creatinine ratio and monitoring that more closely. Both calcineurin inhibitors can cause hyperkalemia and hypomagnesemia. In fact, they cause a Fanconi-like syndrome, so they also have a lot of phosphate wasting, so most of them are hypophosphatemic as well. Cyclosporin is associated with more hirsutism and gum hypertrophy, whereas tacrolimus, it's the hair loss. So in a lot of the young female patients especially, there's a lot of concern for the use of both, depending on, whether it's alopecia or the hirsutism. For things like hypertension, hyperuricemia, and hyperlipidemia, it's more common with cyclosporin. Whereas the hyperglycemia and neurotoxicity in the form of PRESS syndrome are more common with tacrolimus. But even neurotoxicity that's less severe than PRESS, such as memory loss or sort of what our patients describe as fogginess and inattentiveness, can also be pretty common. All right, next case, a 55-year-old patient with end-stage renal disease on dialysis receives his third renal transplant from a 68-year-old donor who died from the donation was after cardiac death. Cold ischemic time ended up being about 30 hours. The transplant was placed in the right iliac fossa where the failed transplant was removed. Initially, there was good allograft function with the creatinine falling from 4.9 pre-transplant to 2.1 on post-op day 2. On post-op day 5, however, the urine output falls to 400 milliliters per day, and a modest-sized 10 by 8 by 10 centimeter perinephric collection is now seen on renal ultrasound. There is good blood flow to the transplant kidney with no hydronephrosis. And the allograft biopsy shows 20% glomerulosclerosis and moderate vascular disease thought to be donor-related. His tacrolimus trough level was 9. 1 week later, the patient remains relatively oliguric. BUN is 30, and serum creatinine was 12.5. Repeat ultrasound shows similar-sized fluid collection, and the repeat biopsies findings were similar to the first. Tacrolimus level is currently 5 nanograms per milliliter. What would be the best course of action? A, switch the tacro to rapamycin because CNI-related renal vasoconstriction is the cause of his renal allograft dysfunction. B, decrease the tacrolimus dose further and repeat a biopsy in another week if there's no continued improvement. C, continue the current management as the patient likely has ATN from the prolonged cold ischemic time, and you suspect that the function will improve over the next week or so. D, sample the perinephric fluid to rule out a urinoma and do a nuclear scan. Or E, continue the current management as the patient has no pain and the collection likely represents a lymphocyte. Go ahead and submit your answers. All right, good. So the majority of you picked the correct answer, which is to sample the perinephric fluid collection to rule out a urinoma. I think the main thing to take away from the case history was the fact that the serum creatinine level was significantly out of proportion to what you would expect it to be, simply due to dysfunction in the allograft due to many of the other potential reasons. And that's because of the presence of the urinary leak, and the urinoma leads to urinary reabsorption and reabsorption of the creatinine that looks like it falsely elevates the serum creatinine. The presence of the vascular disease in the allograft does raise the possibility of vascular compromise being a potential, and one has to remember that it's not only vascular compromise to the glomerulus or the tubulose cells, but actually to the vessels supplying the ureter as well. And so this is actually a risk factor for distal ureteric necrosis, specifically at the UVJ, where the anastomosis of the ureter is to the bladder. A nuclear scan or even an antegrade pyelogram can demonstrate the function of the transplanted kidney and whether there's extravasation of urine into the perinephric space and into the peritoneum. One has to be cautious, though, because sometimes the use of these radionuclide scans, such as MAG3s, if the GFR is low and you don't see much glomerular filtration, they can be falsely negative and not be able to sensitive enough to detect the leaks. It's less likely that the tacro dosing is contributing to the worsening function, especially if you've already dropped tacro levels. And ATN was not demonstrated a bit on the basis of the biopsy, so it's unlikely that it's ongoing ATN, despite the long cold ischemic time. It's possible that the fluid collection does represent a lymphocele, but in the presence of the elevated creatinine levels, one needs to sample to rule out a urinoma to confirm that it is in fact a lymphocele. And of course, we're not always sampling random fluid collections because lymphoceles are common in the post-transplant period, sometimes up to months post-transplant, depending on the patient. But it's unlikely in and of itself to cause such significant graft dysfunction unless it was causing hydronephrosis or unless it was compromising blood flow to the graft. Okay? In the absence of pain and the absence of fever or sort of those signs does not rule out a urinoma. So the next case is a 27-year-old African-American man with end-stage renal disease from primary idiopathic FSGS. He underwent a deceased donor renal transplant about 6 weeks ago. He'd received ATG, followed by maintenance therapy with sirolimus, mycophenolate, and prednisone. His allograft function has been stable at 1.2, but he's been noticing worsening bilateral lower extremity edema. His physical exam is otherwise normal, except for that 2+ ping edema, and laboratory tests reveals a creatinine of 1.6, a spot UPCR of 8, and CBC is within normal limits, and the sirolimus trough level is 7. Which of the following statements is most correct regarding his case? A, predictors of recurrence for FSGS include rapid progression of initial disease to ESRD and adult onset of disease. B, this is unlikely recurrent FSGS since the patient is currently treated with mycophenolate and steroids. C, use of mTOR inhibitors have been shown to cause FSGS. D, this is unlikely recurrent FSGS since recurrence of primary FSGS is very rare. Or E, recurrence of primary FSGS is unlikely to occur so quickly post-transplant. So which is the most correct? All right, so actually, most of you picked A, which is incorrect, and a smaller minority of you picked C, which is actually the correct answer. Okay, so as we've spoken about before, mTOR inhibitors can cause FSGS. Okay. In one study from patients being converted to sirolimus from CNI, 64% of them developed proteinuria and 30% were found to have FSGS. And it's also been associated with the collapsing form of FSGS. And in about a third of the patients after discontinuation of the mTOR inhibitor, proteinuria reversed itself. A was incorrect because actually the major risk factors for recurrence include childhood onset of the initial disease, not adult onset. Of course, rapid progression of initial disease is a major risk factor of recurrence, being Caucasian or a history of recurrence in a prior allograft. There is no association between maintenance immunosuppressive regimens and the risk of recurrent glomerular disease after transplant, and the risk primary idiopathic FSGS remains one of the most commonly recurrent diseases in the allograft, ranging from about 30 to 50%. And in some patients, this can occur within the first 1 to 2 days post-transplant. bringing up the possibility that this may be due to a circulating permeability factor. But the effectiveness of pre-transplant pheresis and even post-transplant pheresis and rituximab is sort of still up in the air. So we should wrap up in the interest of time. So Dr. Milford and I, we put together more questions than we knew that we could get through so that you guys could use that as sort of a reference for your ongoing study.